It's time for your health show. Thank you so much for joining us this evening. My name is Purity Museo and welcome to this program. Childbirth is challenging and complications occur, but women's bodies are designed to give birth. The shape of the pelvis and hormones, powerful muscles and more all work together to help you bring your baby into the world before, during and after childbirth. So today we talk about childbirth. We look at what happens to the body during childbirth and how the body prepares for the same. Welcome once again to the program, and we have Dr. Maureen Owiti here with us in studio. She'll be taking us through the journey of childbirth, what to do and after delivery care for both the mom and the baby. So sit back, relax and enjoy this informative conversation that we are going to have in the next few minutes. Welcome to the show.
Thank you, Purity, and thank you for having me again.
And you know, when we talk about childbirth, it's the end of the journey. During the third trimester, you said that you feel tired and you're looking forward to when is this day coming, when will I deliver the baby, and it's joy. So when you talk about childbirth, what should women expect apart from being happy, the day is here, the appointment with the doctor? Take us through it.
Okay. Now, when somebody, I think in Genesis, when we were in the Garden of Eden, and Eve was tempted by the devil and ate the proverbial apple, gave to Adam, we got a very bad punishment called labor. Oh my goodness. Oh my goodness. And I think whoever coined that word meant it in every sense of the word. Again, to every what is normal, there are always those people who don't experience. There are some people who have one contraction, ameza, and you're looking at them like, gosh, I wish I was you. Majority of the time, labor is exactly that. It's labor. It's something, it's a process. So it's not that you just wake up, get one contraction, and the baby's out. For the few who have that, God bless you, and may God continue to bless you. For the rest of us, let's bear with the labor. But despite that, I encourage women that despite the fact that we're going to go through labor, God has given women the strength and the grace to be able to go through the labor and to be able to deliver the baby and come out on the other side. So it's just having that faith that you'll be able to go through it. And modern medicine has helped such that depending on how your thresholds for pain is, we have various ways of how we can be able to manage the pain to help the woman while she's in labor. So what exactly is this labor? So we diagnose that a woman is in labor if she's experiencing contractions. So these are contractions, I think it'll feel like a cramp. It's normally at the top, the fundus, at the top of the pregnancy. And you'll feel the uterus, if you touch the tummy, it becomes stiff and hard, and then it relaxes. And these are contractions. With the contractions, we're supposed to get changes in the cervix. And the cervix, normally, when we're not pregnant, the cervix is quite long. It's about 3-4 centimeters, and it's closed. And because of the hormones of pregnancy, progesterone in particular, it's going to remain this way until between the baby and the woman signals are sent to start the onset of the labor. As we're nearing the third trimester, the cervix, the connective tissue connecting is going to get softened, and the cervix is going to start dilating and becoming shorter till it remains something as paper thin. So if we're having contractions and we're getting cervical changes, these contractions should make the baby, because the baby is now in the womb, start descending through the pelvis or the genital tract to eventually come out.
For some women, it's just one contraction and your baby is
some
out.
Lucky few.
Yeah, lucky few.
They are very rare and far between. The rest of us, we're going to go through a process. So the labor is divided into several stages. 3, so just like pregnancy has 3 trimesters, labor has 3 stages. So the first stage of labor is the latent labor. Then the second stage is the active labor, and the third stage is from delivery of the baby up to delivery of the placenta. So in the latent labor, the contractions will be far between, the dilatation is not so much. And also, we have changed. Before we used to say that active labor was up to 4 centimeters. Active labor is actually now starts from 6 centimeters. During the labor, we're going to be monitoring several things. We're going to monitor the mother, her vital signs. So is her pressure fine? Is her pulse okay? Is she breathing well? And of course, oxygen. To COVID, I still maintain. Please get vaccinated if you haven't. I've stolen that in there. Then we're going to look at how is the baby. Is the baby lying well? Is the heart rate good? We have some external heart rate monitors that we're able to put a trace and see that the baby's heart rate is doing well. However, if we don't have that, it doesn't impact on the management, because if we listen frequently enough as required, we are with the same level able to pick up any abnormalities. And in fact, those monitors, it has been shown, may slightly increase your rate of cesarean section without improving outcomes for the baby. Babies playing well, is the cervix dilating well, so we do the vaginal examination, and is the head descending well. So in a good labor, you're going to have all of this going simultaneously. So how long does the entire process at the labor? For each mother is different, but at least for once we're in active labor, that is when we can say. Latent labor, we don't want to be more than 12 hours. Active labor from 6 centimeters. For a first-time mother, should take about 4 hours. Shouldn't take more than 6 hours. Progresses well, the head will come down, cervix will be fully dilated. So when we examine, so I'll tell you you're 4 centimeters, 6 centimeters, 8 centimeters, you're fully dilated when you're 10 centimeters, and the baby, you're now ready to push once you're fully dilated. But even that pushing, you have to see where is the head. There are those who dilate, but the baby's head has remained high. More common in people who are on their second or third delivery. You look for features of obstruction. There are no features of obstruction, you proceed with the labor. But if it's a first time and they're fully dilated and the head is there in the sky, most probably this baby is not going to pass through. And those are some of the signs that we tell that, oh, we think unfortunately we have to do a cesarean section. A lot of women get disappointed that why would we put them through the whole process of labor and still take them for a section. We are all agreed that a normal delivery, if there are no other complications, is always safer than doing a cesarean section. There are more complications associated with doing a cesarean section than having a normal delivery. Having had said that, if there's a complication, you have to look at what the complication is. Can we do the cesarean section in a timely manner? You're going to avoid complications for the mother. You're going to avoid complications for the baby. And so it's getting that balance. It's getting that balance of this mother needs a cesarean section. This mother can proceed for a normal delivery. Unfortunately, it's something that you learn over time. We're right, I believe, in majority of the cases. Sometimes things don't go the way you plan.
And how does the behavior of the mother during the entire 3 stages of our pregnancy affect the delivery or childbirth?
So for a well-prepared mother, she understands what is going to happen, but pain is pain. And I say, I come from a community that is known, tunafanya mayo way, and we do drama when we're in labor, okay? And it's just, everyone has a different pain threshold. Everyone has a different experience. You can't say because Purity ni chuma nako labor nako hivi stone face husky ana maintain now Owiti ndio huyo all over the place climbing under the table, under the chair.
Or depends.
The pain is very subjective. As I said, some people have a very high threshold. They can withstand unimaginable amounts of pain. And there are some people, hata unamguza hivi unasharuka, they cannot stand pain. So you have to take each patient as an individual, manage them, there's no shame in labor. For us, all we want at the end of the day, that you climbed under the bed, crawled, removed all your clothes. Us, all we want is that you're okay and the baby's okay. And we'll have a small laugh at the end of it all. And it's part of the, I don't know, I don't want to say it's entertainment, because for you who's going through that, it's not funny. It's not funny at all.
Yeah.
Options for pain management during labor are quite a number, and they start from just simple birth support, having somebody around you who's able to support you.
No painkiller.
It's a pain management option. Then if you want medication, we normally give opioids. So those are the only things that can try to help with the pain. Things like paracetamol will not help with labor pains, okay? High tech would be maybe do an epidural. It's becoming more and more common, but again, we also dissuade, because epidurals are known to prolong the labor and the second stage of labor. So you've gone from the active, so the latent, you're now in the active, so that's still the first stage of labor. So the first stage has two, the latent and the active phase, from 6 centimeters up to full dilatation. Once you reach full dilatation and the head is come down nicely, we diagnose that you are in the second stage. So second stage is from delivery, from full dilatation up to delivery of the baby, okay? Different people have different way they approach this. There are those who want the mother to actively push, and that's majority of providers will want the mother to actively push to enhance the probability of the baby coming out. There are those who feel just let with the proper contractions, the baby can come out, and they feel that you get less tears if you just have a less laid back approach to how you're going about it.
What does it mean to go through an induced labor, and why does it happen?
So just before that, to help with the baby coming out, we also want the mother to try to bend her head so that her chin can get as close to possible as a chest. So when she pushes, so they go, you're not pushing in your chest, you're transferring more of that energy towards the
you're laid back.
Pelvis. No, you'll be lying back, somebody will help you, so either the nurse or your birth partner can help you to kind of just bend your head. Doing that makes that more of the energy when you're trying to push is going in the pelvis and not coming in your chest. Now back to induction. Induction is one of the reasons. So like we've talked about, the most common reason for induction would be the mother has gone beyond her due dates, okay? So say you're pregnant, today is the 2nd of November, okay? And say your due date was on the 25th of October. So it means you've passed your dates. So 25th of October will normally give women an extra week, maximum an extra 10 days to wait for the onset of spontaneous labor. I personally still prefer spontaneous labor, though there are talks that some people are saying that it's safer to deliver at 39 weeks than at any other gestation. But we all know that from point of view of trauma to the woman and her body, that a spontaneous labor tends to be kinder to the body than an induced labor, and you have less complications associated with induction. Induction is not without its own complications. So we'll normally give her an extra week, a maximum of 10 days, to just allow for her to go into her own labor. That doesn't happen, we definitely have to induce the labor, because if the pregnancy stays too long, we're now going to run into complications of what we call a post-term pregnancy. And the most common complication, which you cannot predict when and how it's going to happen, is just sudden infant death. And this is because the placenta, the integrity is not as good, and the amniotic fluid is not as much. So mother's okay, walking about, baby, poof, no baby. And so and other complications of a postpartum pregnancy. The amniotic fluid reduces a lot, so you find with the dry labor, you now have a higher chance of going for a cesarean section. So we really don't want the mother to go way, way beyond, like more post-term will be more than 14 days from her expected date of delivery.
Yeah.
Other reasons for induction would be, say, other complications. So somebody with, say, high blood pressure in pregnancy, you don't want them to go beyond 38 weeks of pregnancy. You'll have to induce them on or before 38 weeks, depending on the maternal or fetal complications.
Right.
You diagnose the baby, say, has a problem, but would require, like, just say a baby is very, very, very small for gestational age, but you feel they're able to withstand labor, you can still induce them. Any other thing, any other complication that you feel would affect either the mother or baby, you can decide that you're going to induce the mother before her due date. Induction has complications. One, it can fail. Okay, so if the induction doesn't work, so induction for us means the mother is not in labor and we're giving medication to help start the labor, that is the contractions.
So induction happens if the mother chooses the normal delivery way?
And,
okay.
And for all mothers, mothers who have not had a cesarean section and don't have any other thing that would compromise her health or the baby's health, the preferred way for delivery would always be a normal delivery, and an induction is trying to go to that direction. Okay, if she has any other thing, like just say she has a placenta previa, and the placenta is covering the entire cervical os, where is the baby going to pass? It is very obvious in that instance that you'd have to do a cesarean section. So we don't have anything that is precluded, so that will be an induction. But a lot of people use induction to mean what we call augmentation of the labor. So augmentation is when the mother is already in labor, but we feel either her contractions are not adequate enough or the cervix is not dilating at a rate that we find reasonable. So we're going to give some medication to help the contractions to be more frequent and more regular, and to also help the cervix dilate. So some people use the two terms interchangeably, but they're actually very different, that I was induced when they are not induced.
I think you've spoken in details about the stages, the two types of delivery. Maybe what are some of the expectations on the part of the mother after delivery, and even how they should take care of their newborns? Okay.
So in terms of after we've delivered the baby, we have to remember that we still have to deliver the placenta, okay? And after delivery placenta, we are going to do a lot of interventions to stop one of the most common killers of mother, which is bleeding. So after delivery, it is normal to bleed, but blood loss should be less than 500 mLs or half a liter for a normal delivery. During a cesarean section, should be less than a liter. So we'll give the mother an injection to help reduce the amount of blood loss after the delivery of the baby. Baby will either be received by, if you're delivered by a doctor, by the midwife or a pediatrician, and in very high centers, even a neonatologist, and they'll do the initial assessment of the baby and any resuscitation if the baby has a problem. In terms of danger signs for the mother, post-delivery, it's always bleeding and the issue of infection. So does she have any fever? Does she have any pain, especially in the abdomen? Is she having a discharge that has a foul smell and things like that? So those would be the danger signs to look for after delivery. For the baby, if the baby is normal, the first sign the baby is not well is this baby feeding well? Okay? If the baby is not feeding well, is the baby irritable, crying a lot? Is the baby urinating well? Those are things that are going to tell you that there may not be a problem with the baby. By the time you get fever and all these other things, it's probably been, you didn't pick up on these other signs that there is a problem.
some of the times we hear cases of maternal complications on the part of the mom, on the part of the child. Maybe you can quickly highlight some of these complications, the causes, and if they can be avoided.
Okay. Yeah. So as I've said, one of the biggest killers is bleeding, and that is the most common complication. In terms of avoiding, unfortunately, there are some cases, like for example, you're expecting a twin gestation, doing a cesarean section, a very big baby, those 4.5 kilo babies, a lot of amniotic fluid, what we call a polyhydramnios. These are people who you can anticipate you may have a lot of bleeding. Unfortunately, a lot of people who get heavy bleeding after normal delivery actually have no risk factors. So it's a high index of suspicion. Healthcare workers who are well trained, well skilled, and able to handle an emergency situation once it occurs. I tell people that obstetricians, we are adrenaline junkies. Because 1 minute your mother is normal, the next minute there's an emergency situation. We have to be able to respond. That stress, even for you, you can imagine you're talking to somebody, all of a sudden she has just collapsed. You have to change condition, manage the situation. That's an obstetrician. And what I love about obstetrician, you want a responsive doctor, look for a gynecologist, obstetrician. We are those people, we are very responsive, we change very fast with the prevailing circumstances that is happening. And
as we wrap up the show, to have list for moms as they go into labor and delivery? I would not be a very good person for that. Normally, most hospitals just have a list on what you need to carry because each facility has what they offer and what they don't offer. In most private facilities, the clothes, nappies, ninis, slippers, soap, yote mtapewa hospitali. So you actually just need to come with what you're going to go home in and what the baby is going to go home in, and probably things like just maybe your innerwear and your toiletries, things like your toothbrush and stuff like that. But most of the time, that's why I say it's important to have a birth plan. In part of the birth plan, you've identified the hospital. You've normally gone to the hospital, and that's what's going to give you a list of actually what you need to come with based on that facility. Because some hospitals, they'll even give you a toothbrush, nini, all of the works. You feel like a nice VIP with all those things. Oh, wow, we have to wrap it up, and I really sincerely want to thank you for being part of this series. We've been with you since the first trimester of pregnancy, the second, third, and now we've delivered our baby. Thank you so much, Daktari. We really, really appreciate your time and presence here.
And I'd like to thank you and hoping to deliver yours soon.
No comment, but every woman wants to. Okay, not every, but
sorry for putting you on the spot.
All right, thank you so much, Dr. Once again, I do appreciate. Thank you to our viewers. Thank you so much for being part of this conversation. I hope the last 4 weeks have been worth your time. We've learned so much from, first trimester all the way to delivery. I'll see you again next week with yet another episode of Your Health. My name is Purity Museo. Stay safe and God bless.